Good morning. I'm Les Wrigley. I've been a volunteer at the Falmouth Hospital Emergency Room for about 22 years. Love being there and have been impressed with staff, with everybody who takes care of multiple patients with so many different kinds of problems. This morning we'd like to focus on stroke as the medical issue, and I have some friends here with me to help flesh this out. On my right, Dr. Michael Leahy, neurologist, who has offices in North Falmouth. To his right, Michael O'Connell, who's one of our ER doctors. Left, Jane Thoreau, RN, one of the nurses I've worked with for a long time. Next, Dan Lopes, who is from the Falmouth Fire Department. He's a paramedic, and he's also a diagnostic technician for us at the hospital, doing wonderful things. And Jean Estes, to the far left, who is our Falmouth Hospital Stroke Program coordinator. Stroke's a major issue for people as they come to us. We'd like to have you think about it from your point of view, and like to start with Mike Leahy. What is a stroke? What are some signs and symptoms?
A stroke is an injury to the brain caused by disruption of the blood supply. Most strokes are from a blockage in a blood vessel where part of the brain doesn't get enough blood. About 1 in 6 are associated with leakage from a blood vessel and bleeding within the brain. What a stroke looks like to a person depends on the part of the brain that's affected. We have an acronym we give people FAST, which describes 3 of the symptoms you would see in a stroke: face or a facial droop, speech or trouble talking, either slurring speech or trouble finding words, and arm, having weakness in an arm. The weakness would not necessarily be limited to an arm. The leg could be affected as well, so a stroke could present with difficulty walking. It will more rarely give difficulty with vision, and often numbness will be associated with it. But the symptom depends on the part of the brain affected, and so the symptoms will vary from person to person.
Okay, Mike O'Connell, what happens when a patient arrives in the ER with a possible stroke? How do we deal with it?
Well, the first thing that will happen is typically we'll get an alert from our paramedic staff who have received a call from a patient coming into the hospital, and they'll alert us that they're concerned that there could be an ongoing stroke taking place. So we'll be ready when they arrive, and once they arrive, you'll have a prompt evaluation done by usually multiple nurses and 1 doctor, and occasionally Jean will be there too, on scene to greet you. And we'll perform a thorough exam, a head-to-toe exam, focusing on the neurologic complaints. You'll get a series of tests done once we're done talking to you and examining you. And usually the most important test that we do is the CAT scan. And a CAT scan of the head is done to get a look at the brain and see if there's any evidence of any bleeding, as Dr. Leahy mentioned, or evidence that there's a lack of blood flow to a specific part of the brain. And that will be done very quickly. Sometimes that'll be done before you're even out of your clothes into the hospital gown. And once you have completed that, there'll be some other tests that we do, including an EKG, which is a picture of the heart, usually a chest x-ray, and you'll definitely end up with an IV in your arm, and we'll check some blood work to see if there's any other possible explanations for your symptoms, because there are other things that can present as a stroke initially, and you may think it's a stroke as a patient, and even as a doctor sometimes we think it's a stroke, and it turns out to be a stroke mimic. So once we've completed all of that assessment, we kind of make a judgment on whether we think this represents a stroke or a stroke mimic, and then we start treating it from there. And that kind of depends on a series of different things. The timing is important, so that's why we encourage people, if you notice any of those symptoms that Dr. Leahy mentioned, you should make the phone call to your local EMS services sooner rather than later, because there are more interventions available earlier, and you may have a better outcome if you're on scene in the hospital earlier rather than later. And we'll get into some of the treatment aspects in this discussion, I think. So.
Speaking of the 911, Dan, what happens when someone calls 911 for a stroke?
So when they do call 911, they will get a hold of a dispatcher, and then we'll proceed to ask them a few questions of what their emergency is, and we'll ask you a few other questions. And it's important to listen to the questions and try to answer them as clearly as possible so the dispatcher can dispatch the appropriate personnel and equipment needed for a call. And if it's a stroke, they definitely want to know that if there's any signs of weakness, and they'll guide you through all the questions that they will ask. And then they will dispatch an ambulance and a few other personnel to respond to the scene for them.
And why is it important, I want to stress, to do 911? Why not drive yourself?
Correct. Some people may think, well, you know, by the time I call 911 and then the personnel shows up and then transports, they sometimes think that if they just put them in the car and bring them to the hospital, may get them there quicker. And that might be, but when you do call 911, myself as a paramedic can notify the hospital a lot sooner and notify them that we are having an active stroke, which just starts a ball rolling for the hospital personnel to do. So even though we may get to the hospital at the same time, things happen at the hospital, and that's already lined up for the patient to be treated a lot more appropriately.
Right, we already have a process in place where Dan would call a stroke alert, which would alert the EMS would alert the hospital would act on that call, we'd call a stroke page, and then we'd have processes in place to get CAT scan immediately ready to see our patient, because that's really the fastest test we want to get done. We want to see if that CAT scan is negative or positive. And although the CAT scan might come back negative, that's a really great step in stroke because we know it's not a hemorrhagic type of stroke, but we're not quite sure at that point if it's not an ischemic stroke, the other type of stroke. And unfortunately, that test isn't so sensitive for stroke. It's like if I whacked Danny in the arm really hard right now, he'd feel the pain and he'd have a deficit and he might not be able to move his arm well. But if I looked at it, there wouldn't be a bruise. But tomorrow, because I'm so strong, we would see that big, huge bruise. And the stroke is similar. It evolves over time. So initially, it might be negative, and we're very happy about that, but it could potentially evolve into a stroke the next day. So a stroke, like we said, has a lot of mimics. The first good test is a negative CT, but that negative CT doesn't mean that we're not having a stroke, an ischemic stroke. But anyway, back to your question about EMS. Notifying EMS first, it's the most important thing to do to get in for rapid care.
Good.
We know what they're doing, they can help us.
Right.
Paramedics too will check a few tests en route.
Correct.
So if you're diabetic and you call thinking you're having a stroke, and
one of those
Dan comes and
mimics that
checks
you were
your
just talking about.
your blood glucose and it's low, well then maybe we can fix that right there.
Correct. Again,
Go
it's
from
one of those mimics that we can easily cross off the list,
Right.
and then work down our protocol
And
to
save you
figure
a
out-
lot of testing and
Exactly.
and stress.
Yep.
So.
The other thing is that patients tend not to come to the emergency room for stroke-like symptoms. They will try to first ignore it. Well, gee, my arm is very numb, but I must have slept on it wrong, so it'll get better. So they wait an hour. Or maybe they think their dizziness is because they didn't have something to eat, so they eat something, and then they wait to get to the hospital. Or perhaps they go to their own doctor and say, gee, I've had these symptoms for a couple hours now, and the doctor will clearly say, well, you need a CAT scan. You need to get to the hospital to have a CAT scan. Other people, like bystanders, will say, hey, you'll be fine. Why don't you just rest? And they convince the patient who has symptoms to sit down and wait it out, when really we're really limiting the options for treatment when patients don't come right to the emergency department.
Right.
And part of the reason time is important is for the 80 or 85% of folks who have a stroke based on a lack of blood flow, we can sometimes restore that blood flow by dissolving a clot. One of the treatments we offer is an intravenous medication called TPA, or tissue plasminogen activator, to dissolve the clot and restore blood flow. If the injury to the brain is from lack of blood, restoring the blood flow will be helpful. If the injury to the brain is long-standing, however, hours or more, sometimes restoring that blood flow is not only not effective in improving the patient, but the blood going into brain that's already injured can worsen the stroke. So we talk about trying to get the clot buster in as soon as possible, and certainly before 4.5 hours. And because there's that time-limited window, we would like to see patients very early in the course of their stroke.
And that's another important thing that you were just talking about, is time.
Yes.
You'll hear it over and over again by EMS and doctors and nurses, is the last known well. And that's a question that you will hear quite often. And and it's kind of important to realize, when was this person seen normal last?
Exactly.
And I'm sure you could probably...
Yeah, there's some examples of that. For instance, if somebody goes to bed after watching Jimmy Fallon and it's midnight, and everybody knows that person walked to the bathroom and they had something to drink and they brushed their teeth and they kissed their wife goodnight, and they get up the next morning at 6 o'clock and suddenly they can't move their right side or they can't speak. Well, the last known well time was truly midnight, when the patient was seen well, and they were found at 6 o'clock unwell. So
Right.
the
Not
time,
6 a.m.
right, the time goes way back to midnight instead of 6. As opposed to the person that's eating breakfast at 8 o'clock in the morning and suddenly drops a cup of coffee, and then you can see that time, exactly when that incident happened, was the last known well
Right.
time.
And it could be them dropping a coffee, or them garbling funny things out of their mouths that not making sense.
Right.
The obviously facial droop that you'll see one side weak is an important thing, because some people might just think the garbled speech might be something else, but that's another sign that they should kind of keep an eye on.
Exactly.
And you'll likely be asked that question multiple times.
Multiple times,
You'll
different
be asked
ways,
by the
multiple
dispatcher,
times.
you'll be
Yes.
asked by the paramedic, you'll be asked by Jane when
Yep.
you arrive to the hospital, you'll be asked by the physician who sees you in the emergency department.
And it's tricky because somebody might think their medical history, well, a couple weeks ago I had a cold, and that's not really what we're referring to. We're referring to the neurological symptoms. When did those neurological symptoms start?
Yes.
And when were they suddenly different from what was normal? That's what we're concerned about. I always say anything that happens suddenly, except for maybe winning the lottery, is not a good thing. So if something suddenly happens to you, we want to get it checked out.
Yeah.
Jane, what happens when a patient arrives at the hospital from a nurse's point of view, when you suspect stroke, so forth?
Well, we already know by EMS that we have a stroke alert, so CAT scan is ready for them. We have the physician at bedside. We get them on the ER stretcher, and we try to go directly to CAT scan.
Okay. Term mini stroke comes up. Where does that fit into the picture?
It usually refers to something called a transient ischemic attack. People have symptoms, speech trouble, arm trouble, vision trouble, that go away. About half the time when you do an MRI, you'll see some change, some small change that went with it. Half the time you won't find much of anything. But the issue with that is it may be a warning of something larger to come. People without symptoms, who have these small symptoms that have cleared, will not get the clot buster because there's a little risk to the medication. What they will get is an evaluation to see what their risk is for a recurrence of this or recurrence of a larger stroke, and a set of medication adjustments to try to limit that risk.
So the risk factors the risk of that medicine is significant in the fact that if we gave this TPA medicine to 100 people, 94 of them would do okay or do better, but 6 of them wouldn't do well. And out of those 6 that wouldn't do well because of the medicine, 3 of them could die. So we're very, very particular on how we evaluate these patients that come into the hospital and whether they're candidates for this medicine. And it's not because they have the right insurance or because we like them or because they look good or whatever. It's whether their symptoms are significant enough, there's enough deficit to treat, and whether the risk of treating outweighs, or the benefit of treating outweighs the risk of treating. So
the hazard from the medicine is bleeding. It thins the blood. So that's part of the reason we're so anxious to get a CT right away. If the stroke is one of the 1 in 6 with associated bleeding, the medicine will clearly make it worse. And the longer you go from the stroke, the longer after the stroke the medicine is given, the higher the risk becomes, to where the risk becomes greater than the benefit after about 4.5 hours.
And that again leads to a lot of the questions that we ask. It's like, have you recently had surgeries? Are you already on any blood thinners, to kind of help you guys decide if that's going to be the appropriate medicine.
Right, that's a great point to bring up, Danny, is to make sure the patients understand what medicines they're on.
Yes.
And if they're on any of those anticoagulant medicines, those are very, very important to tell a physician or a nurse if you're in the hospital. We need to know those medicines especially.
And not just with strokes. It would help out immensely. What I'm about to talk with next is the file of life that you can get at your local department. And it sticks right on the refrigerator. A lot of the guys will walk inside the house, guys or girls. We'll walk in and we'll look on the refrigerator, see if there's a file of life, and that is a great time saver, because instead of now me asking, what meds are you on, what's the dosages. I can easily just take that piece of paper. It has their name, date of birth, the meds, past medical history, and that saves on my time, on scene time, so I can take them to the hospital a lot quicker.
Right, and no matter how sharp you are, if you are sick with a stroke or anything else, your answers to the questions probably won't be quite as good. It's nice to have them written down in advance.
Yep. That is a great help.
What about that other treatment, Mike? Do you want to talk about that?
There's a newer set of treatments that are more recent, where they put a catheter into the artery and try to retrieve a clot, actually physically take the clot out. This is done primarily in larger centers. We have a working relationship with Brigham and Women's who do that. The timing on that can be much later than the TPA. It seems that this can be effective as long as a day after a stroke, but only certain patients are eligible. The clot has to be in a certain place, technically the internal carotid artery or the proximal middle cerebral artery, just two main arteries to the brain. If the clot is removed, the brain then gets blood, and restoration of some degree of function is possible. There are patients we will see who come in with a significant stroke later than 4.5 hours, or who are on a blood thinner that means we can't give the second blood thinner, who would be candidates for this procedure. We would screen them in our hospital with a test called a CT angiogram, a CT scan with dye to look at the blood vessels. And if the blockage appears to be in an appropriate place, and the patient is not too far out from the stroke, we will talk about a transfer for clot removal. This will be uncommon. For most people, this will not be a consideration, but there are folks in whom this will limit what could otherwise be a devastating stroke.
Thank you, Mike. I guess I would ask, what are risk factors for stroke? What should people be aware of? What should they do before having one?
The primary risk factor of stroke is hypertension, and in fact, stroke incidence has decreased significantly over the past 30 years because we're better at treating blood pressure. But that's the strongest statistical association with risk of stroke. There is an increased risk for an elevated cholesterol, so that's also something that ought to be addressed. Diabetics have more strokes than non-diabetics, and there's a specific risk for smokers. Smoking gets blamed for everything, but it is a specific risk factor in stroke. And when we see a young person with a stroke, someone under 60, there's a disproportionate number of smokers involved in that group.
And the good thing is about, not the good thing, but something that people might not be aware of is that they can actually go to the local fire station and get their blood pressure checked. Mm-hmm. It's quite routine that people will kind of walk around the neighborhood, stop in probably once or twice a week. We kind of meet them, we check their blood pressure, they document it, and then they're on their way. You know, that way they keep an eye on their blood pressure if they have a history of it.
I'd like to stress something with that, though. If your blood pressure's been controlled to a degree, and then one day it's 190 over
Correct.
90,
yes.
It does not mean you are going to have a stroke that day.
Right.
Because we get a lot of people who come in the emergency department and say, I'm worried I'm going to have a stroke. My blood pressure was high today. And it's not that type of issue, typically. Right. It's a long-term control issue with blood pressure. Yes. So that might quell some fears, because I see that at least once or twice a week where someone comes in with no symptoms,
but they check their
but says my blood pressure's higher than usual, I'm going to have a stroke today. Yeah. But it doesn't work that way. So that's...
People are also concerned with atrial fibrillation. There's a lot of our community that are on medicines for atrial fibrillation. It's another risk factor for stroke.
Right.
And I'm sure we see lots of them in the ED.
A whole lot of AFib, and that is an important risk factor, and that's why that's important to have that treated with a blood thinner typically.
Right. The treatment, the blood thinners used in atrial fibrillation are different from those used otherwise. The blood thinners used for stroke prevention are primarily aspirin or aspirin variants, unless patients have atrial fibrillation. In that situation, a stronger anticoagulant like Coumadin or one of the new ones, Xarelto or Eliquis, is much more effective than aspirin in blocking a stroke. There is some risk of bleeding and with Coumadin some nuisance value for blood tests, but because they are so much more effective in preventing a stroke, twice as good in patients with atrial fibrillation, we'll advocate for using those medications.
Should people who think they're doing a stroke take aspirin before they call or before they do anything?
That's not nearly as clear as with a heart attack. With a heart attack, it seems to make a difference. With stroke, it's not clear. There are two considerations. One is someone who's had a stroke that we will eventually put them on aspirin, usually in the first day. There's clearly some benefit. But the converse to that is there's a little bit more risk of bleeding with an aggressive intervention like TPA in someone who's just taken an aspirin.
Yeah, the other thing Jane and I would know is they have to have something called a dysphagia screen, which is a fancy word to say a swallow test before they can swallow something. Sometimes when people have strokes, they don't realize that they can't coordinate the muscles to swallow well. And in doing so, they could actually choke on that aspirin. So that would be a not such a great thing to do at home, to try to give someone an aspirin and have them choke on that and have issues when they were getting in. They'd develop an aspiration pneumonia or something, a problem, because they couldn't swallow effectively. So when they get to the hospital, we are absolutely not putting anything in their mouths until we screen them to see if they can swallow appropriately.
Yeah. It's also important to note that more rare stroke, the bleeding type of stroke, cannot be differentiated on just talking to you or your symptoms. So we don't want you taking any blood thinners like aspirin prior to coming to the hospital in case you're one of those rare cases where you have a bleeding stroke already, and then you've just added another problem to the mix. So we would discourage that in general.
And a comment on the swallowing issue. In addition to stroke being less common over the last 30 years, people's recovery from stroke has been better. One of the reasons it's better is that nursing care and evaluation is much better. And in particular, we have an awareness of aspiration pneumonia, of things going down the wrong pipe, and protect people who've had a stroke from that. And that's part of the reason that people recover better now from a stroke than they did 30 years ago.
Right, with rehab. Our rehab department is excellent, and they do amazing things with helping people get back to their regular activities. So, you know, they're wonderful.
When you have a brain injury from a stroke, your brain will recover, but it recovers by finding the back roads, by finding the other pathways that will help it work. And as in learning anything, the way you learn to do something, the way you activate a brain pathway is to practice it. That's what rehab is about. Some folks who've had a stroke who have trouble with mobility are not going to be able to manage at home for a while. They're going to need some training to deal with the new problem and to revise the home setup. And those people will need inpatient rehabilitation. But even people with less trouble would benefit by staying with rehabilitation to let the brain develop those new pathways.
Thank you. Gene, earlier you mentioned the NIH Stroke Scale. Gene or Jane, tell us what it is, how it's useful.
The NIH Stroke Scale is composed of 11 items that we score people's specific impairment to a stroke.
Exactly. So it's fancy words to say it's a little test that we give our patients, and it will ask them to answer a couple simple questions like what month is it and how old are you. We'll follow down looking at their face, their eye movement, whether their arms can stay up for 10 seconds, their legs for 10 seconds. We'll test their sensation, and we'll show them a card like this with simple pictures that just, we want to see if they can tell us that this is a cactus and that's a glove or a hand. And we grade them, we score them. And it's the only test that you want to get a 0 on, because, or one of the only ones, because a 0 means you didn't have deficit that was measurable. So when I see Dr. O'Connell in the hospital or Dr. Leahy, and I tell him that his patient has a NIH Stroke Scale of 10, that cues him into think the next treatment option, which would be, in that case, either TPA or endovascular procedures. So it's a great way that we can all communicate about a patient without saying, well, his right arm is weak and he can't speak and ba. Rather, if I say he's got an NIH Stroke Scale of 10 or 15, we know exactly on the scale of how much deficit this patient has and whether treatment should be warranted, rather than if I say, well, this patient has an NIH Stroke Scale of 1, and that might be for slurred speech, and that might be from a whole other problem other than stroke. It could be alcohol, it could be a lisp, it could be a lot of different things. So it's just a way to measure stroke deficit.
Right.
It seems like it's a pretty quick test, even though it's like 11. I'm sure the nurses and doctors.
Jane's fast at it.
Yeah, they could probably whip right through it.
Try to do it before they even get off the EMS stretcher to CAT scan.
Exactly.
Right.
Or even just to know a couple things right
Right.
off the bat, so we can say to Dr. O'Connell, this is what's going on with your patient, and he comes in immediately and he says, absolutely, let's go to CAT scan. So it just makes the process go so much faster. We're all talking the same language.
Nice.
Mike, do patients always get admitted with stroke or TIA symptoms?
Typically, yes. Typically, if you come in with something that appears to be, well, we'll talk about them separately. TIA, so a TIA mini stroke, you're going to tell me, I'm going to tell you your testing all came back and looks generally okay. Your CAT scan's negative. We don't see anything else concerning other than your story. You know, your story sounds like it fits the bill for a possible mini stroke or TIA. And at that point, it's a risk stratification game. You know, just Dr. Leahy had referred to this earlier. It's kind of figuring out not only did this happen, but why, and how would we prevent it from becoming a real stroke, you know, that can leave you with deficits later. So that's the important piece, is getting you in, observing you for 24 hours or so, having some further testing done, including an MRI that is typically done. Ultrasound of the carotids is typically done to look for plaque. Echo, an ultrasound of the heart is sometimes done, and some other tests to check your cholesterol and whatnot to stratify out where could this possibly have come from and how do we prevent it from happening again.
Right. The stakes are almost higher with a TIA, a mini stroke, than with a stroke, because you've got everything left to lose at that point. You've got nothing wrong with you, and you don't want to develop something wrong with you. We'll be looking, one of the important tests is a carotid ultrasound. If there's a significant blockage right here at the angle of the jaw, we know that clearing that significant blockage greater than 70% will limit the risk of stroke significantly. The other thing we'll do is we'll have folks on a heart monitor for 24 hours and see if they have atrial fibrillation, because our treatment strategy is very different in that. And it will seem sometimes to a patient in the hospital, they went in, they had 15 minutes of symptoms, they all went away. What's the big deal? The big deal is you're fine now, we want you to stay that way.
Yep.
Certainly if you're on the other end of the scale, where you're left with facial droop or speech difficulty, or your arm or your leg is weak, and we decide you're a candidate for that clot busting medication TPA, well then that comes along with a free trip to Boston. Well, not free, but a guaranteed trip to Boston.
Right.
You're going to be sent up to Brigham and Women's Hospital for more dedicated, potentially an endovascular technique.
Right, and we do that with something called telestroke, which is
Right.
a kind of a HIPAA-approved Skype. So we make the patient and the nurse and the physician movie stars for a little bit of the time, where this physician from Boston can help us evaluate, a neurologist from Boston helps us evaluate our patients, and we decide whether that patient should receive this medicine, and if they do get the medicine, they're given the drip, and then they're shipped right up to Boston, and follow-up care will be done up there. And then I usually get a call from me, because I like to see how our patients are doing for the next 5 days or so. I call them and talk with whoever their loved ones are to see how everything's doing, and then I get a follow-up report from Brigham after that. So it's a great, we have wonderful physicians here and wonderful physicians there, and it's a great meshing of the minds and the resources.
If you're kind of in the in-between where you have the deficits but you don't meet the criteria for the clot buster, we will admit you to the hospital in Falmouth, onto the inpatient medical service, where Dr. Leahy, as the neurologist, will likely be consulted to make further decisions about how to help you and prevent further issues, and decide on what should be done next.
And a lot of this is working with our hospice and our nursing staff. We've set up a program, Jean did much of the hard work, where our nurses on the floor are aware of what you need to do for stroke education and what medications you need to consider. Our hospitalists are aware of that as well. We have a checklist we will follow through to be sure everybody leaves on some kind of a blood thinner. We've checked the cholesterol, that we've at least addressed the blood pressure, though sometimes those adjustments are later, and that everybody's had a rehabilitation evaluation. We want to give folks both the best chance of recovering from this stroke and the best chance of avoiding another.
Are there any other comments that any of you would make on stroke issue?
We've covered a
Covered
lot of information.
A lot of ground. Yeah.
I think I would wrap up then by asking, How long should I wait with symptoms before I come to the ED? Circling back to where we were before.
Well, you could give it a whole minute.
And that's 30 seconds too much.
Good. Well, thank you. Appreciate all of you being here. Hope that audience has learned something, will learn something as they watch the TV. Thank you.
Thank you.
Thank you.
Thank you.